Dr. Lulu Mathews, coming from Institute of Palliative Medicine, former HOD, Pediatrics, Government Medical College, Kozhikode. Dr. Lulu Mathews.
Palliative care, it provides relief from the symptoms of pain and physical stress and mental stress at any age of illness. For this, our former HOD of Pediatrics, Dr. Lulu Mathews, now is involved in many much in palliative care and is a pediatrician also. And for her talk is Pediatric Palliative Care. Professor Lulu Mathews, please.
Okay. Good evening, everybody. I'm really happy to be here. And I was often asked by the person who was phoning me, what would be your title? So I said, I will come up with a title. And the title is this: why isn't the IAP doing anything about children's palliative care? Why don't us or you, the pediatricians, do anything for children's palliative care? And that is the topic of today's topic. So this is actually, I thought it would be a good night, but I'm happy that I'm able to start at this late hour. And I'm coming from the Institute of Palliative Medicine, Calicut, where I am working for the past 10 years. Now I am seeing some of you calculating. That means madam must be 62 plus 10, 72. But I'm happy to tell you that I retired when I was 55. So I am -7 from what you think you are. Anyway, for the past 10 years, I am working here. So, see, in children's palliative care, you know, when a child, what's the greatest tragedy which can befall a family? That is the death of a child. What is the second tragedy, most tragic incident? A child being diagnosed with a chronic illness. And the day of parents are told that their child has a chronic illness, the sun is set for the family. The family becomes helpless, hopeless, powerless. And not only the parents, the grandparents, that too the maternal grandparents, the paternal grandparents, the uncles, aunts, they all come to you with a child. And that is the magnitude of the problem, how it is affecting the family when a child is being affected with a chronic illness. Yet, the provision of children's palliative care world over is very, very scanty. And what's the reason? Mainly lack of finances. Lack of finances in the sense, we don't have a definite, no national studies regarding the magnitude of life-limiting illnesses in children. So we have no documents to present to the government to ask for budgeting. So nothing goes into the budget for a children's palliative care. So that rarely leads to lack of finances. And again, lack of trained professionals. See, in our umbrella organization, Indian Association of Palliative Care, where there are thousands of doctors, only just 4 pediatricians. And that too, only in the last few years they have come up. Initially, I was the only one. So definitely lack of trained professionals and lack of awareness about children's palliative care among the public and the policy makers. So large numbers of children are living with life-limiting illnesses. And you know, they need not only just palliation of symptoms, but they also need psychological, social, emotional, and spiritual support. Not only the child, but the entire family needs your help. And if you look at the conditions, childhood cancer leads the list. But there are other conditions, hematological conditions, hemolytic anemia, sickle cell anemia, hemophilia, unoperated congenital heart diseases. A doctor, he was speaking about those diseases which can operate. But there are such a lot of diseases, heart diseases, where nothing can be done. What about the neurologically handicapped kids? The static encephalopathies, the progressive encephalopathies, cerebral palsies, degenerative CNS conditions. The list goes on and on and on. And what are we pediatricians doing for these children? Nothing, I should say. Because all children diagnosed with a life-limiting illness, they need your support. They need our support. Not only the children with cancer. And nurses can provide it, trained staff can provide it, family physicians can provide it, pediatricians also can provide it. I'm putting pediatrician the last because pediatricians seem to be the least interested in children's palliative care. And CPC can be offered in the hospices, in nursing homes, in hospitals, and even at home. But only thing, the attitude or the philosophy of children's palliative care, that should be started at the time the diagnosis of a chronic illness is made, not when it has progressed to a stage when you know nothing more can be done on curing for the disease. See, palliative care developed in India, it is there in India since the 1980s, yet the national coverage is just 1 to 2%. But if you take Kerala as a whole, 35% are under cover of palliative care service. But northern Kerala, 70% is under care of palliative care. That is general palliative care. But what are the barriers to the development of CPC, children's palliative care? Mainly, us pediatricians, we always equate palliative care with terminal care. And parents go all out for curative therapy. And parents are not ready to accept the death of a child. And even the most common symptom in children, pain, even pain is under-assessed, under-managed, or even mismanaged. We don't manage pain. That's a real truth. And another tragedy is that wherever CPC exists, it's all attached to major hospitals. See, we have one attached to the Government Medical College, Kozhikode, another attached to SAT, and still another one attached to Trichur Medical College. So everybody thinks that there should be a big institution, only then one can develop CPC. Okay, so why is it that? What is the reason that pediatricians should show an interest in children's palliative care? See, we have learned pediatrics for a diploma and also for a degree. We have been living with them, and we are earning our lives because of these children. We know their body language. We know their play language. We know their spoken language much better than adults. But still, only thing, we are not becoming involved in it. What about the children's understanding? Say, we know that it goes through various stages. They also have understanding about health, illness, death, and dying. It goes through various stages. And this depends upon not only their chronological age, but also on their developmental age. Not only on their developmental age, but also the cultural setup in which they are being brought up. Say, a child who is growing up in Kerala, a 6-year-old child, can be equated with a 10-year-old child growing in a villages or in a Tamil Nadu. So a lot to depend, not only on the chronological age, but also the developmental status of the child, and also the culture and the dynamics of the family in which the child is growing up. And again, you see, you think children have no idea of their illnesses and death. But sometimes if you talk to children, they say, I know I am sick. And then after some years or after having gone through some months of their illness, the child starts telling, okay, I am sick, but I know I will get better. But after some time, he reaches the situation, realization, I'm going to keep on getting sick, but still I will get better after each episode of my disease. And then at last the realization sets in, and then the child says, I'm going to keep on getting sick, but I know I will not become better. And then I know I am going to die. So this occurs in the various stages of a child's disease. It all depends upon what is that child's developmental age at that point of time. If you interact with a child, you will be surprised to find out that how much the child knows about his or her illness. So what can be done? See, one thing is you should dispel the myths. You should disseminate the facts. Pediatricians, we should believe the children. We should believe that children have pain. Okay, what are the myths? We believe children and infants don't really feel much pain. But the reality is that the children are more sensitive to pain, much more than adults. We believe children have no memory of pain, but they definitely have a very good memory. See, even a newborn who is taken to an immunization clinic, the second or third time the mother walks into the clinic, the baby starts crying. Why? The baby remembers the pain. Children, they remember pain, they don't forget pain. But what's the difference between us and children? Children remember the pain, they forget who inflicted the pain. We adults, we forget the pain, but we remember who inflicted the pain. That's all the difference. Otherwise, we are all same. And we believe there's a myth that if you expose children to opioid medications, they will become addicted. Again, that is a pure myth. We believe children cannot decide their own level of analgesia, but if you talk to them and if you spend some time with them, I mean, we find out that they can indicate what is their level of pain, and we will be able to give them proper analgesia. We always believe that children exaggerate, but it's not the truth, especially adolescent boys. Adolescent boys never want to admit that they have pain because they want to be like their fathers. So if I admit I have pain, they will think that I'm not as strong as my father. So children don't always exaggerate pain. And we medical professionals believe we are good at assessing childhood pain, but we are really very, very bad in assessing children's pain. So if anybody wants to assess pain in children, this is a very, very easy mnemonic. Onset. When did the pain start? What are the precipitating factors? What brings on your pain? What are the palliating factors? What relieves your pain? What is the quality? Like, what is your pain? Please describe the pain. Where is it spreading? That is the radiation. How bad is it? How severe is it? Temporal relationship. Is it more when you walk? Is it more when you cough? Is it more when you sneeze? So if you just remember these letters, you can really understand and manage children's pain. Okay, so this is a very easy, universally accepted Von Baker Faces Pain Rating Scale. You show this to a baby, to a child, and ask him, see, I know you are having pain. Which among these faces is your pain? If the child says, this is my pain, this is my face, this is my face, that means the child's pain is 8/10. The numerical value given is 8. So 1 to 4, it is taken as mild pain. Okay, 5 to 7 taken as moderate pain, and 8 to 10 taken as severe pain. And again, see the difference. Here, suppose a boy or a child has severe pain, and he does not want to show this. Why? He might be thinking, this fellow is crying. I am not crying, so I cannot show that. So in order to omit such thing, we have the revised scale. See, no tears here. So the affective qualities like the smile and the tears have been removed. And again, the same question you ask the child, which among these is your face? And that will help you to find out how severe the child's pain is. Or you can make it very colorful. Okay, the principle is the same. You are allotting a numerical value to the child's pain. So it could be anything. It can come in any size, shape, instrument, color. This is again very, very simple. So mild pain, moderate pain, severe pain. So you can ask, is your pain this much, this much, this much? So mild pain, moderate pain, severe pain. So that is as easy as that. You don't have to spend any time at all. Or if you have the time, you can give them a body figure, give them crayons. You please give colors wherever you have pain. If you have little pain, you color yellow. If you have more pain, color blue. If you have very bad pain, color red. So only when the child paints different parts of the body in different crayons, you understand that the child has not one pain, but 3 or 4 pains. And again, when you talk to them, you have to use the simplest. For example, I'll tell you, you are asking a child, "Mone nalla vedana undo." The child says no. So you say, okay, the child has no pain. But what have you taught a 2 or 3-year-old child? Nalla means good, cheetah means bad. And what have you asked? Moinu nalla vedana undo. So what the child has answered, there's nothing nallad about my pain. That means child is telling I have severe pain, and you are taking the opposite meaning. So you have to be very careful even when talking to the children. Okay. So, I went into some detail about the severity, but remember, it's not all that important. Just because a music is loud, it does not become good. Just because a music is soft, it does not become bad. Severity is important, but don't give undue importance to measuring the severity. Okay, so pain in a child is an unpleasant sensory and emotional experience, and it's an inherent quality which appears very early in life, because the structures of nociception are present even in early gestation. So the same stimulus can evoke more pain in a child than in an adult, more pain in a baby than in a child, and more pain in a newborn than in a baby, and more pain in a fetus than in a newborn, because the inhibitory pain system is not developed at birth. Only as the child grows up, the inhibitory pain signals are developed. Okay. So even auscultation can be painful if not done properly, right? And pain in children is most often ignored. At best, it's what the mother feels. I often give a simile. When a mother feels cold, she gives a sweater for the baby to wear. When the mother feels cold. Similarly here, the mother thinks the child has pain, we also believe child has pain. But pain is treated far less regularly, and many procedures are done with physical restraint. In fact, this photograph was taken in the side room of Ward 54 in 2003. I distinctly remember this. This was how the picture was prior to an LP. And we believe we ignore pain in children. We believe children are crying because of hunger or fear. We again believe children don't have pain. And we don't give importance to procedural pain management at all. So it distresses the child, the parents become angry and unsatisfied, the physicians are frustrated, lack of complaints. And all this can be set right by giving proper procedural anesthesia. See, pacifying, see the upper picture. This is a nurse trying to take sample, but the father is called in. The child has become very quiet. So the presence of the father, age dependent, you can give sugar water or even distracting the child's attention while procedures are being won. The use of EMLA cream. I'm sure you all know how to apply EMLA, and it is available. And please consider pain as the 5th vital sign. See, this is a simple thing. I've showed you the scale. So every time when you take, every day, you ask the child, how much is your pain? Suppose 19th, it was 8. 20th, again 8, 7, 5. You are giving medication, the pain is, the severity is coming down. Suddenly, 25th, you find the pain scale is more. So only if you record pain, as you record your pain, temperature, BP, then only you will realize that your child has pain, and you will be able to treat your child. And the non-pharmacological measures like toys can be very effectively used. The presence of a parent, I've told you about it. Therapeutic play techniques. You can use crayons, puppets, magnetic boards, hospital equipments, dolls, everything can be used. This again a picture taken from the leukemia ward of our government medical college, Kozhikode, and she is Varsha. She is given crayons, and this what was done. Those paintings were put up on the walls. Adolescent children, when you go for rounds, you will find that the tip-top, hair is neat, well-dressed. So you might think he is very well. That is why, no. Adolescents are very bothered about their looks, about their personal appearance. So don't think that just because he looks very smart, he is not having any symptoms. And again, they would rather be with their peers than with their parents. So please remember these tips. And again, you can dress up your patient as a doctor or a nurse. and give a doll for him to work through. So then that child knows no doctor will try to inflict pain on them. And again, if some of you are working in Wi-Fi, hi-fi hospitals, pet therapy, if a child has a pet, it can be brought into the room. Then the 4 P's of pain management, I am coming to the end. The pharmacological, the physical, psychological and procedural. I have just taken immunization as an example. Pharmacological, applying the topical anesthetics like EMLA or giving sugar water. Physical, holding the baby upright or breastfeeding. Psychological, distracting the baby or deep breathing. Procedural techniques, rapid intramuscular injection without aspiration, and giving, if there are more than 1 pricks, give the most painful the last. Small things, but if you take some time, you can. And using a 2-step strategy, that is the drugs given by the mouth, by the clock, and by the ladder. Please know how many hours each of the analgesic is working before you give it. And it's a 2-step ladder. Mild to moderate pain, it is non-opioids, and moderate to severe pain, it is opioids, and the drug dosages. And now at least it's a good omen, because in the recently so many pictures of you all celebrating children's name. So far you were only giving medicines and giving pricks and injections. Now you have started enjoying. So, but there's a problem. All the pictures which came up in the WhatsApp, they're all focusing on the doctors and the house surgeons. But I would be very happy. This is how Children's Day is celebrated, was celebrated IMCH. Children, all patients dressed up like this, okay. Again, celebrating Onam with a flower carpet, or Christmas like a Christmas papa. Deepavali 2018, this from Trichur Medical College. These are all cured patients with on-present patients. Again, this is C4CCI Punarjani 2017. So the focus is on children, not on doctors and house surgeons. Please, if you have any time, please read this book by Imran Hashmi. This is a person who acts only in films. But when his son Ayan was diagnosed with Wilms tumor, how he utilized it to treat this. If you have the time, please. Children, palliative care is not a super specialty. It's an attitude or philosophy. You can easily incorporate it into your daily practice. Children are born with rainbows in their hearts, and hope you reckon the rainbows and reach the children. And one good thing about, I am summing up, after even the incoming president, Dr. Santosh, he used to, not Swans, but the state president, he used to call me every now and then, irregular intervals, talking about children's palliative care. Now, after being chosen as the state president, he is now calling me at regular intervals. So I am very hopeful that at least in next Pedicon, from the tail-ending position, the children's palliative care or palliative care will be given at least a middle order batsman position, not Dravid's number 4, somewhere down 5 or 6, but not from the tail ending position, because palliative care is in Kerala since 1993. And Kerala is the pioneer in palliative care. And I sincerely believe high time the Pedicon started giving more importance to palliative care. Thank you very much.